the Women at Risk board for many years and also served as the president of the organization and was a great friend to all of us. Laurie was a really strong advocate for breast cancer awareness and education, and that is why we are so honored to hold this event in her memory. And I wanted to welcome her sons, Zach and Craig, and other members of the family who will be with us tonight. I would like to give a special thanks also to the friends and family of Laurie Beth Sklaver and to Sanofi Aventis for funding tonight's event. And I also would like to give a shout out to Amy Whiffen, who coordinated everything tonight. She's our high-risk and research program coordinator. For those of you who are not familiar with Women at Risk, we are the breast cancer program at Columbia University Medical Center of New York-Presbyterian Hospital. Our mission is to enhance the lives of women who are high risk for breast cancer or who have breast cancer through research, education, and support. We have a number of different programs. I know many of you are familiar with them. We fund research. We have a high-risk program and registry, patient navigation, support groups, community programs, and much, much more, and educational events such as tonight's. And next year, we're very excited to be celebrating our 20th anniversary, and we're just thrilled to have reached that special milestone of helping women. If you're interested in learning more about us, please check. There's lots of information at the table outside. Just a couple of things to know for tonight. If you should fill out a raffle entry card if you didn't already. The Women at Risk staff will be around, and if you need one, please flag one of them. We're going to have 5 raffle prizes at the end of the evening. And make sure to put your email address on it so that we can keep in touch about future events. Index cards are for questions, which are going to be with the speaker panel at the end of the event. And again, we'll have staff walking through the aisles to collect your questions. So feel free to write those up. And last but not least, all Women at Risk events such as this are free to the public. And there's a donation envelope inside the newsletter, which you got at the front when you checked in. And we hope you will consider making a donation to support Women at Risk's work. I would now like to introduce Dr. Kathy Ann Joseph, who will be moderating tonight's event. Dr. Joseph is an associate professor of surgery at the New York University School of Medicine and director of breast services of the South Manhattan Network for the Health and Hospitals Corporation. Prior to recently joining NYU, she practiced breast surgery at Columbia University Medical Center for 7 years. Dr. Joseph was the medical director of Women at Risk for 3 years and was also Women at Risk's first fellow. And we were very pleased to have the opportunity to work closely with her over those many years. Please join me in welcoming Dr. Kathy Joseph.
Thanks, Kitty. Good evening, everyone. We have a wonderful panel of both physicians and patients who are going to educate us and are going to share their experiences with us tonight. This is a wonderful topic and a very interesting topic to talk that we're going to discuss today. As a breast surgeon, we deal with breast cancer. We deal with breast cancer all the time, and while no one wants to be diagnosed with breast cancer, when you are faced with that diagnosis, it's usually very straightforward as far as what you need to do. I mean, there's no ambiguity about what needs to be done. You know that you need to be treated. But when you're high risk, there's a lot of, it's sort of like walking down a path and you sort of reach that fork in the road where you have certain paths that you can go down. And as a doctor, we really don't necessarily we can't always tell you what path you have to take. You sort of have to take all the options and decide what's best for you. And so tonight, that's what we're going to do. We're sort of going to go over all the paths that you can you can take, and then you can decide what's best for you. And the patients are also going to talk about what options they chose, and they're not all the same, and it's all very interesting. And I'm going to start with our first speaker, Dr. Chong, and Dr. Wendy Chong is a clinical and molecular geneticist. She's the Herbert Irving Assistant Professor of Pediatrics and Medicine at Columbia University's College of Physicians and Surgeons, and she directs the Clinical Genetics Program at Columbia University. In her research lab, she works to identify new genes for breast cancer and determines genes that work with BRCA1 and BRCA2 to decrease the risk of breast cancer in mutation carriers. We're excited to have her here tonight to speak about the benefits and limitations of genetic information. So let's welcome Dr. Wendy Chong.
Thanks, Kathy, and thanks everyone for having me here. I'm very excited to see so many people come tonight, and hopefully to be able to share with you some of what we know, and as Kathy said, a lot of what we don't know, but to be able to manage risk as we go forward. So again, one of the points that I want to emphasize that Kathy made also is that as we're talking about some of the issues that I'm going to talk about, to test or not to test, meaning genetic testing, there's no right answer for everyone. So, and even for an individual person, that answer may change over their life course. There may be a right time in your life to think about testing, and there may be a wrong time in your life to think about testing. And so for every individual person, it's kind of a journey that you go through and a process that you go through. So I'm going to give you some of the sort of thoughts that a lot of people have, but just to let you know, again, this may not be the right answer for you, and that's perfectly okay. So one of the things that is remarkable to me is, as a geneticist and as we've completed the Human Genome Project for over 10 years now, you may not be able to read this very well, but this Time magazine cover was back from 1994. And so, in fact, even 15 years ago, people were saying the time is now, genetics is now, this is all done, and even with BRCA1 and 2, when you think about it, that's about the time that BRCA1 was identified, and shortly thereafter BRCA2. And in many ways, I have to say I'm disappointed in people like me that we've gone really 15 years at this point about knowing these genes. And we certainly know more than we did 15 years ago, but there's an awful lot that we still haven't figured out. And so I just want to be perfectly honest and frank with you. Things are complicated, and it's complicated because we actually have 19,900 some odd other genes besides BRCA1 and 2 that are very important, as well as what we do in our very daily lives. What we eat, what we drink, what we do in terms of our exercise and having children also plays a role in all of this. So what we're talking about today is our genetic blueprint, and we're going to be talking more about these BRCA1, BRCA2 genes, really named BRCA1 and BRCA2 because they were originally thought to be breast cancer genes, but as we're going to be talking about tonight, they really are breast ovarian cancer genes. They're two of the powerful genes, but as I said, we know that there are many, many other genes as well, and we're not smart enough at this point to know all of the BRCA 3, 4, 5, 20, and 30s that there are, but there are many other genes as well in this. But I am not personally a genetic determinist. That is, I don't think it matters just what is in your genes, but I think there are things we can do in the everyday way we lead our lives, as well as what we do in terms of screening and choices that we make in how we lead our lives that can actually be able to empower us to prevent cancer, or at the very least to be able to detect it at an early stage. And so that's what we're going to talk a lot about today. So let's start with people that are near and dear to us, our mom and our dad, our kids, our family members. And for some of us, we know a lot about our families. Some of us, we may not, and that's okay. There's some people, obviously, who are adopted or who may be estranged from their families. But your family is actually, the information you can get from your family is probably the best information that you personally can use to try and stratify both your risk for cancers as well as lots of other things. Risk of Alzheimer's disease, cardiovascular disease, many other things as well. As we talk about family history, there can be some powerful genes. And again, when we think about this, about 5 to 10% of women who get breast cancer get it because of these two powerful genes, BRCA1 and BRCA2, that are over here at the left. These really trump. These are epidemiological risk factors here. So lots of other things you may have heard about or read about when you had your kids, if you had your kids, whether or not you took things like hormone replacement therapy. All of these things really are trumped by these two powerful genes. And so I don't, again, want to say that if you have a mutation in one of these genes, you necessarily will get breast cancer, because that's not at all true. But again, some of these other factors are not nearly as important as these two genes are if you happen to have those. A lot of people ask me this question every single day. I got breast cancer, and why? That's the sort of big question that haunts them. Was it something that I did? Was it some gene that I got from my family? And I have to say, in probably 90% of the cases, I nor anyone else can really truly answer that question of why. But in a small percentage of women, somewhere between about 5 to 10% of women, we can't actually answer, at least in part, that question why. Again, there are these two genes, BRCA1, that accounts for about half of those cases of very strongly, powerfully genetic cancers, about a third of those cases due to mutations in BRCA2, and importantly, another slice of that pie that's not insignificant due to other single genes that are powerful, and we just don't know what those are at this point. But again, this is a minority of women who get breast cancer are due to these genes. An important minority, but a minority nonetheless. These two genes are inherited in a way that we call autosomal dominance. And what that means is that everyone has two genes, one that they get from their mom and one that they get from their dad. If you happen to have a mutation in one of these genes that you're born with, and that's the way it works for most of us, that they're born with, one of your copies of your gene is perfectly fine, but one of them has a mistake, has a typo, usually a couple letters out of 3 billion letters in our genetic alphabet that are different. If you're born with this one copy working perfectly fine, it continues to protect you from breast cancer for as long as your one normal copy is working. It acts as the brake, the safety device for you. If something should happen to you over the course of your lifetime to that other copy of that gene, though, you've lost your brake. And now you can't stop your car, you can't stop your breast cells from starting to grow and starting to grow out of control in a way that goes to breast cancer. So when we see this in families, we see a pattern that sometimes doesn't quite make sense. Sometimes we see generation after generation after generation of women who have had breast cancer, some of them ovarian cancer, but these genes can actually be carried by men. They can pass through men, sometimes silently. So maybe you may not see the pattern if it's coming from the dad's side of the family. In addition, there are women that carry mutations in these genes, but again, for their whole life, their one other copy of their gene works perfectly normally, and so they never ever develop cancer. And so it can look like it skips generations within families. But if you have a mutation in one of these genes, you have a 50-50 chance of passing it on to your children. It's like flipping a coin. Even if you yourself have never developed cancer, even if you yourself are a man, still a 50-50 chance of passing on this gene to a child. Why do we care about these genes? Why would you care to know if this were in your family or if your breast cancer were because of these genes? And the main issue is because the risk of cancer, the risk of either having one cancer or potentially of having another cancer is really much higher than it is for the average woman. So again, if we think of the average woman having a lifetime risk on average of about 10% over the course of her whole lifetime, a woman that has a mutation in one of these genes could be as high as 50, 60, 70 upwards percentage chance of developing breast cancer. And those numbers are no joke. And that's, again, if you don't do any intervention in terms of being able to prevent cancer. In addition, and this is one of the hardest things that I hate, is that it's not only a risk of breast cancer, but also a risk of ovarian cancer. And in many ways, I have to say, ovarian cancer to me is scarier than breast cancer just because we don't have ways of screening for it and detecting it at a very early stage. And I have to say, what breaks my heart is a woman who's fought breast cancer, who survived breast cancer, and then gets blindsided by the ovarian cancer because she didn't realize that she was at increased risk. And that's, at least for some of you, one of the reasons why some women who've had breast cancer themselves think about testing, is because of that fact alone. Their risk of ovarian cancer, again, it's a relatively rare cancer in the population, 1 to 2%, but if you carry a mutation in one of these genes, could be 20, 30, 40% risk of ovarian cancer, again, without good methods of screening. So, in addition to that, there is a higher risk not only of ovarian cancer, but there's a higher risk of a second breast cancer, so not just a recurrence, but an independent new primary breast cancer. And so at the very least, we want to continue to do intensive screening after a woman's had her breast cancer. And like I said, some women will choose to do things that are more aggressive in terms of either surgical options or medical options to be able to manage that risk. You may be sitting there and thinking about your family and thinking, do I fit into this pattern? Is this something that I should be worried about or think about? And I'll tell you some of the things that we look at when we look at our families. Families that likely have hereditary breast ovarian cancer, the most strongly predictive factor is someone who's had ovarian cancer in the family. That's the one factor that's most predictive. Sometimes what's difficult to know is older generations didn't always know it was ovarian cancer. Sometimes it was just called a female cancer or, something down there. Sometimes cervical cancer by people didn't know. And sometimes even things like stomach cancer, abdominal cancer, because it was kind of in the belly. So sometimes this gets masked, but ovarian cancer is certainly the most relevant. Breast cancers that are early, so women who are in their 20s, 30s, 40s, more likely to have this, and women who've had bilateral cancer, more likely to have this. As well, we tend to see it coming from one side of the family, and as I told you, it can come through males, so the dad side of the family is relevant. What's less likely to be one of these strong hereditary cases is where we tend to see breast cancers that tend to be older, women who are in their 60s or 70s. And in this particular case, it's coming through both sides of the family, rather than in this case where it's coming all through one side of the family on the dad's side. One of the other factors is depending on where your family comes from in terms of your ethnic background, there are different prevalences of these mutations depending on what your background is. And so if you happen to be Ashkenazi Jewish, and if you just walk the streets of New York as someone who's Ashkenazi Jewish, not even knowing anything about your family history, there is a 1 in 40 chance that you carry a mutation in one of these two genes. And that's because there are 2 mutations in the BRCA1 gene and 1 BRCA2 mutation that have been passed down generation through generation within that population. There are certain other population isolates. I know it's probably not anyone from Iceland here tonight, but if you happen to be from Iceland, that's another hot spot. But really, no one is free from this. So in other words, I've seen families from all 4 corners of the world who have mutations in these genes. It's something that we see not infrequently. So just a couple things that you already realize at this point, but your dad's side of the family matters within this. Ovarian cancer is a part of this, and family history is important in terms of age of onset more than anything else. And so those are the factors to look for in your family. So we've talked a little bit about what you could do to try and figure out whether you're one of these individuals. Well, why the heck would you want to know this? I mean, some people might say, well, you know, this is just going to be a bummer, right? I'm just going to worry about this. I'm just going to get anxious. I'm just going to be living under this black cloud. I don't want to be there. That's not me. Well, the reason you might want to know this, and again, I'm not saying this is right for everyone, and especially not at certain times in your life, but that I do think that if you do know this information, you can be empowered to do something about it. That is, you can do something productive to make sure that you don't get blindsided by this. What are some of your options? Well, number one, we can look very intensively for this. And I mean not just a manual mammogram, but I also mean more intensive things like breast MRI and being very vigilant to see your breast surgeon and making sure that you've got someone watching your back. In addition to that, we can actually reduce the risk of breast cancer. We can use chemopreventive methods like tamoxifen, other similar aromatase inhibitors that we now have to reduce the risk of breast cancer by up to 50%. And I think that's a wonderful risk reduction strategy. In addition, and it's certainly not the method that all women choose, but surgically there are options in terms of prophylactic mastectomy. And I would say in my experience, this comes mostly with women when they do get a diagnosis of either ductal carcinoma in situ or breast cancer. They feel like that's sort of their warning sign, their knock on the door, and they're not going to play with this anymore if they've been doing management with surveillance up until that point. Again, I'm not saying that's everyone. I do personally find it interesting that as we're seeing a lot of younger women that are thinking about this, again, I think it's a selection bias of who's doing this, but many of the younger women are actually making decisions to be more aggressive from a surgical point of view, realizing that if they make a decision to be aggressive when they're young, they can really just sort of shelve it. They don't have to worry about this very much anymore. They can go on with their lives, and we have many great options in terms of reconstruction. The more difficult case in many ways is the ovarian cancer risk, and we're going to hear in gory detail about all of this, so I'm not going to go into too much detail, but suffice it to say that as of today, I'm very disappointed to say we don't have a great method of screening for ovarian cancer. And so my philosophy, as is most others, is if and only if you know that you're at high risk for these genes, once you're finished having your kids, and this is usually for women when they're post-40, it's time to take out the ovaries rather than run a risk of really having a deadly cancer. And again, this is something that can be timed, and there are options in terms of prophylactic surgical methods, doing it laparoscopically to minimize the recuperation time. But most women, I think, would rather not have to worry about ovarian cancer because it is very silent until it becomes deadly. For some of the younger women, there's also an additional factor, which is using birth control pills. Oral contraceptives can reduce the risk of ovarian cancer by as much as 50%. To me, that's a win-win situation for many of our young people. So, why would you want to do this? Well, you might do this for yourself. I also have to say you might do this for your family. And many women that I see, quite honestly, they do it for their sisters, they do it for their daughters, they do it for their nieces. They may say, well, I wouldn't do anything differently for myself, but you know what? My kids may have to worry about this someday. They may have to worry about the risk of ovarian cancer in particular, and maybe I would like to be able to give them this gift of knowing this when they want to know this. And I should have said this earlier, but it is always most informative to test someone who's actually had one of the cancers in the family rather than someone who's simply at risk based on their family history. By testing someone in the family who's actually had the cancer, we're the question, why did you get cancer, and do we have to worry about that same thing in your other family members? Again, the greatest gift that I see people giving in families is when they themselves, for instance, a mother finds out that she has one of these mutations, and then she has her daughter, or at least her daughter at some point decides to get tested, and her daughter finds out she's negative. And that's just a wonderful feeling to know that you know why you got your cancer, you know why there's been cancer in the family, and you can actually take someone off the hook. And I have to tell you, there have been so many women where their daughters worry and worry and worry, and to be able to get that once and for all sense of relief and know that if they don't have it, they're not going to pass it to their kids or their grandkids, it really is an amazing thing within those families. So obviously, I can't guarantee that's going to happen, but when that does happen, that is one of the reasons why some women choose to do this. Well, why wouldn't you want to do this? Obviously, because this can cause a lot of anxiety. Certainly, there are some women who are just nervous Nellies, and I understand that, and for some of them, there are very good reasons to do that. But they would say, you know what? I'm just gonna lay awake at night. I'm not going to be able to function. I'm not going to be able to do something productive with this information. I'd rather just act as if and go about my merry way. And in many cases, that's fine in terms of the breast cancer risk, but the variable becomes with the ovarian cancer. They may not want to go ahead and have a prophylactic oophorectomy for nothing, but they would get pushed to do that if they knew they had one of these mutations. One of the other problems with our testing, and our testing has changed over time for any of you as women who had testing many years ago, it doesn't detect all mutations in BRCA1 and 2. It's gotten better over time, and there have been improvements. And it also doesn't detect all mutations in all genes for breast cancer. In fact, it only detects a small portion of those. So if you've had breast cancer and your genetic test is negative, importantly, there still is a familial factor within your family that will increase the risk for other family members. So let me say that one more time. Even if you've had breast or ovarian cancer and you test negative for this gene, BRCA1 and 2, there could be some other gene in your family, a BRCA5 or 6, that we don't even know about and haven't even tested you for, that still could increase the risk for other women in your family. So a negative genetic test doesn't get you off the hook unless you know for sure what the genetic factor is in your family that's causing the breast cancer. One other thing that I want to raise that some people get concerned about is this idea of discrimination. Will this come back to bite me or someone else in my family if I know that we're marked in some way with having a genetic risk factor? And so the good thing I can report to you now is that Congress 2 years ago passed something called the Genetic Information Non-Discrimination Act, or GINA. Went into effect in 2009, and it protects anyone who has a genetic predisposition from either being discriminated in terms of health insurance or employment. So you can't have your health insurance rates raised, you can't be denied health insurance, you can't be denied a job or denied a promotion based on a genetic predisposition. And that's for any genetic condition. Where are you still vulnerable? Well, you're still vulnerable, in theory, when it comes to things like life insurance, long-term disability insurance. We don't have the same federal laws protecting us when it comes to that at this point. Most insurance companies are playing the don't ask, don't tell policy, so that if they're not asking if you've had genetic testing, and I certainly wouldn't offer that information, but that is the one place potentially where there is some vulnerability. So as we go on tonight, certainly you're welcome to ask me questions as we do with the panel, or certainly catch me afterwards, and anytime afterwards, please feel free to jot down my number, my email address. I know this is going to be an exciting panel, and again, I thank you for inviting me.
Thanks, Wendy, for that great informative talk. Next, we're going to have Dr. Ruth Oratz, who's going to give us some more information on the management of your risk for breast cancer. And Dr. Oratz is a board-certified medical oncologist who specializes in the treatment of women with breast cancer at her practice in New York City, the Women's Oncology and Wellness Practice. She's a clinical associate professor of medicine at the New York University School of Medicine and is a fellow of the American College of Physicians. Dr. Oratz has participated in clinical and translational research for more than 20 years and is widely published. We are glad she could join us this evening to talk about opinions and decision-making for women at high risk of breast cancer. Thank you.
Thank you, Kathy, and thank you, Dr. Chong. That was really, I think, a very important introduction to understanding a little bit about these genetic risk factors for breast cancer. I would like to focus specifically on breast cancer. We're going to be hearing a little bit later on about ovarian cancer. So let me push the right button. Here we are. So we've been focusing in terms of our conversation about genetic risk on the two genes that we know the most about, BRCA1 and BRCA2. We know, as Dr. Chong explained, that women who have mutations in these genes are at significantly increased risk for developing breast cancer and for developing a second breast cancer, even if they've already been diagnosed once. And these are the same sorts of range of risk that you saw in the first presentation. But not every single individual who has a mutation in one of these genes will necessarily develop breast cancer. So even if that lifetime risk for, let's say, a BRCA1 mutation is as high as 50, 60, 70, 80%, it's not 100%. There are lots of other factors that weigh in on whether or not, as Dr. Chong, I think, so nicely explained, something else happens to the rest of those genes to make that cancer develop in the individual. We know also that amongst individuals who carry these mutations, all of the cancers aren't the same. So the age of onset may vary. There may be other risk factors coming into play. Some of these may be hormonal, environmental, and lifestyle. So even if we look at women in the same family who carry the same mutation, they may not necessarily express the outcome of that genetic mutation in the same way. So we talk about penetrance. This is a little bit of a complicated slide, and I'm stepping into the genetics territory here. But penetrance is the proportion of individuals who carry a genetic characteristic who actually then express what we call the phenotype. So in this case, the phenotype is developing breast cancer, and the genotype is having the mutation. So what's the penetrance in a family? And this is a paper that was published a few years ago that was looking at different families and saying, well, is there a variability from one family to the next in how much this mutation in BRCA1 or BRCA2 penetrates into the family? And if you look at the column on the right, there's both breast and ovarian cancer on this slide, and by risk at age. So if you're 30 years old, and you have a mutation in BRCA1, the risk of developing breast cancer is about 2%. And that risk increases over time. So when we say there is a 70 or 80% risk of developing cancer if you have one of these mutations, it's important to realize that what we mean is lifetime risk. That doesn't mean on the day you're born, your risk of cancer is 85%. That means by the time you get to age 70 or so, there will have been an 85% chance that you may have developed breast cancer. At each point along that time curve, your risk, if you have one of these mutations, is higher than the general population. But that doesn't mean that an 18-year-old girl who learns that she has a mutation, or even a 30-year-old who learns that she has a mutation, is at an 85% risk on that day of developing breast cancer. So there's some variability here by age, but we also know that things have changed over time, and this is a phenomenon that we haven't yet been able to explain, which is called the cohort effect. So when we look at families, and Dr. Chong alluded to this, where let's say there's a mom who's 75 years old, she's never had any cancer at all, and then her daughter comes in to see me because she's been diagnosed with breast cancer and she's 38 years old, and I say, okay, you're 38 years old, you're Ashkenazi Jewish, maybe there is some other family history of some cancers, and we test that young woman who's had the cancer, because again, we want to look at the person who developed the cancer first. We find that mutation, and then we say, well, which parent did this come from? It could be from the mother or the father. And let's say we then test her mom and find out that her mom was the carrier, has the mutation, but never developed cancer. So what we see when we look historically at many of our families is that for women who are born, let's say after 1940 or after 1950, the age of onset seems to be a little bit younger. So something has been happening in the last 20, 30, 40 years where the breast cancers, at least, are showing up in mutation carriers at an earlier age. We're not really sure why that is. Possibly environmental factors, maybe diet, maybe hormonal factors. So there's still some teasing out that we need to do there. Are there other genetic risk factors that still need to be identified that are getting switched on or switched off in these individuals? So that's something that we're also struggling with in our research studies. When a woman finds out that she is at high risk, and I just want to go back to my very first slide where I said we're defining risk and focusing on these genetic risk factors, but there are a few other genes that we know about other than BRCA1 and BRCA2, and we also know that for women who come from high-risk families, even if they don't have a mutation in BRCA1 or 2, but multiple family members with breast cancer, that in and of itself increases your risk of developing breast cancer. Maybe not to the same extent that a mutation in BRCA1 or 2 does. So the first thing is to understand what your level of risk is. Now, if you have already developed breast cancer yourself, well, that's the highest risk, right? So you've already developed the cancer. Going forward, we're concerned first and foremost about making sure we treat that cancer, do everything we possibly can to prevent a recurrence, and then pay attention to making sure we think about your risk for developing other malignancies, whether that's a second breast cancer, ovarian cancer, or what have you, and taking steps to try and prevent or reduce the risk of those. So the first thing is understanding what your level of risk is. And that's where the conversation with the genetic counselor is so important. And then the second issue is, okay, what do I do with this information? So we know that there are lots of different options. These are complicated decisions. Your decisions should be based on information. And I would advocate that there's really a team of people who are involved in helping to make these decisions. Medical oncologists, GYN oncologists, surgical oncologists, plastic surgeons, the genetic counselors, and a lot of psychosocial support. These are tough decisions for everyone at any age. So take your time as you think through what is my level of risk and what steps do I need to take. It is rare that there is an emergency requiring a decision to be made overnight. So for women who learn that they are at significantly increased risk for breast cancer, whether or not that's because of a BRCA mutation, what options do we have? And Dr. Chong mentioned that we have surveillance programs, risk-reducing options that are surgical, and risk-reducing options that involve medical treatments. We call that chemoprevention. That doesn't mean using chemotherapy. That means using medicine. I think we have to come up with a better word than that. These strategies will be different for each woman and will be different for any individual woman depending where she is in her life. So again, for that 22 or 23-year-old young woman, her set of choices may be in kind of one zone. For someone who has completed all of her childbearing and maybe is 40, she may feel differently about how to approach her risk. For the woman who, let's say the mom of that patient who I treated who's 70, who all of a sudden finds out she has a mutation, but she got to be age 70 and never had cancer, she's going to think differently about how to manage her risk. So it's not a one-size-fits-all answer, and even for the same individual woman, her decision about how to deal with her risk may change over the course of her lifetime. So let's talk a little bit about surveillance for breast cancer. Breast self-examination is still important. It may not be the best way to detect breast cancer, but if you notice a change in your breast, you feel a lump, the skin changes, there's a nipple discharge, or the nipple looks funny, or whatever it is, go to your doctor, check it out. It may be nothing at all, but it may turn out to be something that needs attention. So we still think self-examination is useful. An examination by a physician is also helpful. So go in for that annual checkup, see your gynecologist, see your primary care doctor, have a doctor examine you and make sure that you're also doing self-examination correctly. There's been a lot of controversy about the recommendations around screening mammography. But I will tell you that after all of that controversy and discussion over the last year from different organizations and task forces and so on, the recommendations of the American Cancer Society, of the American College of American Society of Clinical Oncologists, the American College of Radiology, the Association of Breast Imaging. Am I leaving any groups out, Kathy?
American Society of Breast Surgeons.
And the American Society of Breast Surgeons still recommend annual screening mammography for women at age 40 who are at average risk. If you are at increased risk, we might begin screening a little bit earlier. We do not currently cap and say, okay, when you're 70 or 75, stop screening for breast cancer. But as women get older, and particularly much older, so we're talking about in their 8th and 9th decades, we wouldn't say don't have any screening, but again, you have to look at what's going on with that individual woman and what the risks and benefits are for continuing screening every single year at that point. There may be some women who are not at increased risk and for whom screening every year and a half, 2 years is not unreasonable between ages 40 and 50, but we certainly feel that screening should begin at age 40. The current recommendation is still annual screening mammography. There are other modalities that can be used in addition to mammography to help us image the breast and can help in breast cancer surveillance. So the mammogram is still the best modality we have for screening. Screening means we're looking at lots of people, so big populations. It's very cost-effective, and it's an excellent test. Where does mammography and mammogram fall short? Particularly in younger women or in women who have very dense breast tissue, because the mammogram is an X-ray of the breast. And if that tissue is very dense, it may be difficult for us to see through all that background noise and detect that little cancer. Ultrasound can be very helpful, particularly in younger women who have dense breasts or in women who have very nodular breasts when you examine them and it's hard to tell, is that a cyst, is that a fibroadenoma? The ultrasound, which has no radiation and can be done very easily in the outpatient setting, can be very, very helpful in identifying solid masses or cystic lesions or even small breast cancers. The problem with ultrasound is that it is somewhat user-dependent. Not everybody does the ultrasound the same way, and it does take an experienced technician or physician to really be able to do a good ultrasound exam of the breast. What about MRI? We've heard a lot about the sensitivity of MRI in picking up cancers that might not be detected by mammograms or by ultrasound. Just as a little background, in general, we say that mammography will detect somewhere between 80 and 85% of breast cancers, which means that in 10 to 15% of the cancers that are in the breast, mammograms won't see them. That could be because of breast density, could be because of other factors. The MRI imaging technique uses magnets, so again, there's no radiation. It's a very, very, very sensitive test. Picks up all kinds of little spots and dots, and you can see on these pictures all these little white dots all over the tissue. Not all of those white dots are cancer. So one of the issues we have with MRI is that it's extremely sensitive, but not extremely specific. So that means every dot we see is not necessarily cancer. In one study that compared mammography to MRI, there were 45 cancers overall that were detected. And if you look at the way this plays out, about half of them were seen on MRI but not on mammography. About a quarter of them were seen in both modalities. And then 18% or so were picked up on the mammogram, not picked up on the MRI. So there's no single modality that's perfect. Overall, as I said, MRI is very sensitive but not necessarily as specific. So one of the disadvantages for MRI is that, first of all, it's very expensive. For any of you who've had to fight with an insurance company about getting this test paid for, you know it's several $1,000s. The exam can take between 30 and 45 minutes. For women who are premenopausal, we know that there's a lot of variation in the density of the breast tissue and the appearance of the breast tissue on MRI, depending on where they are in their monthly cycle. So we have to time the exam for the right time of the month, and that's sometimes a little tricky. The MRI machines for breast imaging are still the closed MRI machine. You lay flat on your belly and kind of go into that tunnel. So for some women, that's uncomfortable and difficult. If there are metal devices in your body, pacemakers, aneurysm clips, whatever, these are very strong magnets. So we need to know about that and make sure that there's no risk for you to go in this strong magnet. And there are lots of different MRI machines out there. So the test has not been standardized in quite the same way as mammography. Remember, we've been using mammograms now for many decades. So one institution could have an MRI machine, let's say that's 10 or 15 years old, and will give one kind of image, but another imaging center might have a different magnet, or they may be slicing the images in a different way, or the computer may be generating the images slightly differently. So sometimes it's hard for us to compare an MRI from one institution or one imaging center to the next. So that's a little bit of a disadvantage. And sometimes we have to repeat the exam, and there are these false positives, which means we see all these spots and dots. We're not always sure whether or not it's cancer, and that may lead often to doing biopsies, which, thank goodness there's no cancer, but it can be very stressful for patients to go through this experience of having a test, having biopsies, waiting for the results. And for women who are at high risk and are going to be doing this frequently, that's not something to take lightly. It can be a significant problem. So surveillance is self-exam, physician exam, and all of these imaging strategies. The right program to set up for each individual patient is something that should be done on a case-by-case basis. We've heard about risk-reducing surgery. Well, what does that mean? So for women who are at very high risk of developing breast cancer, and here we really are talking about the BRCA mutation carriers, doing mastectomy, and here we're talking again about a total mastectomy, in the studies that we have so far, reduces that risk of developing breast cancer by about 90 to 95%. So it's not 100%. And we started to do these procedures, let's say 10, 12 years ago, if we knew about the BRCA1 gene about 15 years ago. So we have 10 years now of experience of women who've had bilateral mastectomies as a risk-reducing option. And all of us who've been in practice long enough now understand that 90 to 95% does mean 90 to 95%. We all have seen a few individuals who come into our offices 7, 8, 9, maybe even 10 years after having had surgery and still develop a breast cancer. And that's not because the surgeon didn't do a good job, and it's not because the pathologist didn't look carefully at the tissue. It's because we can't be certain that every single microscopic cell has been removed, even by the best surgeon. And we've seen these breast cancers develop either at the very lateral edge, sort of far out on the side, or superior to where we think the breast tissue has been taken completely, and even sometimes in a lymph node under the arm. So it's rare, but it does still happen, and we cannot say if you do mastectomies that there's a 100% guarantee of never developing breast cancer. There are a lot of excellent plastic surgery techniques for breast reconstruction. And we have a new technique in mastectomy, and Dr. Joseph can answer more questions about this later, which is the nipple and skin-sparing mastectomy. But I will tell you that in women who carry mutations in BRCA1 or 2, we do not have the long-term follow-up data about the efficacy and safety of that procedure. So that's a relatively new approach. Chemoprevention means using medication to help reduce the risk of breast cancer. The two medicines that we have experience with so far are tamoxifen and raloxifene, a kind of cousin drug to it. And we know from a number of series that tamoxifen reduces the risk of breast cancer by about 50% in women who are at increased risk. We don't, and the same is true for raloxifene, by the way. But what we don't know is, are these agents equally as effective in mutation carriers as in women who are at increased risk just for other reasons? Where we're looking to in the future is developing new drugs that might be more effective at preventing breast cancers, and there are a number of clinical trials going on looking at that. And as we mentioned earlier, there are a number of other factors that interact with our genes that may be switching on or off some of these issues. We know that obesity, particularly in postmenopausal women, certainly increases the risk of breast cancer. Alcohol intake, drinking every day, for example, is a real risk factor for breast cancer. We know that exercise helps reduce the risk. Adequate vitamin D levels and good sunshine helps, we think, to possibly reduce risk. And there are some other medical treatments that may or may not interact with the genetics, with the environment in the body and the hormones in the body to interact to either increase or reduce risk. So I'll stop here and answer questions later on in the panel. Thank you.
Thank you so much, Ruth, for that very enlightening talk. I just want to make one housekeeping note. We are taking questions because after our next speaker, we're going to have a panel discussion. So if anyone has any questions, just write them down on the index cards, and Amy and Kim are walking around and they're collecting them. So our next speaker is Dr. Sharon Lewin. And Dr. Lewin is a GYN oncologist who specializes in ovarian, endometrial, uterine, cervical, vulvar, and vaginal cancers. She's an assistant clinical professor and a member of the Division of GYN Oncology in the Department of OB/GYN at Columbia University Medical Center. She's won numerous teaching and research awards and has authored over a dozen articles and textbook chapters. We're thrilled to have her here to speak about options and decision-making for women at high risk for ovarian cancer. Dr. Sharon Lewin.
Good evening. Thank you for that nice introduction.
I had an AV tutorial before I... There we go, little slides. Yeah. You may have to...
How are you tonight?
Fine.
Thank you. That's great. Thank you for the opportunity to be here. It's really an honor. I just want to talk a little bit tonight about options for women at high risk for ovarian cancer. Just want to talk a little bit about ovarian cancer in general, and then particularly the risk for ovarian cancer in women with high-risk mutations. So according to the American Cancer Society, approximately 22,000 women will be diagnosed with ovarian cancer in 2010. It's the 9th most common cancer among women, and it's the 5th leading cause of cancer-related deaths in women. Ovarian cancer in general really accounts for about 3% of all cancers in women. So if you're looking at women's health care in general, the percentage of women who actually receive or unfortunately have ovarian cancer is quite small. Thankfully, that's very good news. The lifetime risk for ovarian cancer among women in the general population is approximately 1 in 70. So 1 in 70 women in the general population who do not have a high-risk mutation are at risk for getting ovarian cancer. But as Dr. Chong spoke about, the risk among BRCA mutation carriers is significantly increased, depending on the type of mutation. It can be anywhere from 10 to 11% higher, all the way up to 40 to 60% higher. So if you're looking at risk groups for ovarian cancer, we can basically break it down into 3 different risk categories. So the average risk for ovarian cancer, the risk among women in the general population who do not have a mutation in one of these genes, BRCA1 or BRCA2, is approximately 1.4%. And these are women that have no family history of early onset breast cancer or other risk factors. Factors that are associated with an increased risk for ovarian cancer, which sort of translate to about a 2 to 5% lifetime risk, are women that may have infertility requiring IVF or in vitro fertilization, women who have never had children before, women who have a single first-degree relative with early onset breast cancer, and that's considered under the age of 50, and then women that have a single first-degree relative with ovarian cancer. So these are factors that have an increased risk, somewhere on the order of 2 to 5% increased lifetime risk. And that, as we've spoken about tonight, the other group of women are women that definitely have factors that have an increased risk, anywhere from a 10 to 11% lifetime increased risk, all the way up to 40 to 60%. And these are women that have one of the delirious mutations in BRCA1 or BRCA2, as well as a constellation of genes called HNPCC or Lynch syndrome, which does cause a constellation of cancers in families, of which ovarian and breast are definitely part of, as well as stomach and colon and uterine cancer. If you look at ovarian cancer in general, the majority of cases of ovarian cancer are not related to any type of genetic syndrome. 90% of ovarian cancer cases are what's called sporadic, which means they arise in women that have no significant family history for any ovarian or breast cancer. Only approximately 10% of these cancers are related to some type of hereditary or genetic mutation. And as Dr. Chong alluded to and told already, the majority of these cancers are related to BRCA1. That's approximately 70 to 75% of our already 10% pool, so it's very, very small. Approximately 20% are related to BRCA2, and then this Lynch syndrome or HNPCC that I mentioned accounts for approximately 2%. The other smaller portion of the pie are related to genes that we have not yet identified. So I'd like to talk a little bit about the strategies for women that are at high risk for developing ovarian cancer. And as I mentioned, BRCA1 and 2 mutations only account for approximately 10% of ovarian cancers that are diagnosed. So it's a very small percentage of ovarian cancers in general. However, when we know someone has a mutation in BRCA1 or 2, there are definitely modalities and things we can do to really reduce their risk, and that's what I'd like to talk about. Unfortunately, there are no good screening methods for ovarian cancer. If I can teach you one thing when you leave here tonight, that's what I'd love you to learn. That's the most important thing, is that unfortunately we have no good screening method for ovarian cancer. That's because the ovaries are free-floating organs in the peritoneal cavity. They're not encapsulated organisms, and so the whole pelvis and abdomen are really at risk. Unfortunately, we've tried many different screening modalities. Many studies over the past 10 years have looked at different screening tools for ovarian cancer, and unfortunately, they don't work. So if I can teach you one thing tonight, that's what I'd really love you to go home with. And many people, even since '94, and the same sentiment applies today, is that if we did have a good screening method for ovarian cancer, that we could really shift the paradigm, and that these women would be diagnosed with ovarian cancer at a much earlier stage, where their survival and prognosis would be far better. Unfortunately, most of the cases of ovarian cancer are diagnosed at very advanced stages because the symptoms are very insidious and we don't have a good screening mechanism. So who are the women who should consider risk-reducing strategies? As we said tonight already several times, if a woman has a mutation in BRCA1 or BRCA2, depending on where you are in your life and various personal factors, I would strongly encourage that she consider a risk-reducing strategy. Any woman that has a high-risk personal or family history who may have had inconclusive genetic testing, and these are some of the most challenging cases to actually talk about. A lot of collaboration among the surgeons and genetic counselors as to best strategies for these particular patients. And the last group are women that have a very high-risk personal or family history who have not had genetic testing. For various reasons, we really don't advocate this approach. It's obviously best to have genetic counseling and screening and testing so that we know exactly what mutations we are thinking about and dealing with. I do want to talk about ovarian cancer screening, even though we've already said that it doesn't work, but just want to talk about some of the utilized methods, a little bit about C125, transvaginal ultrasounds using color Dopplers to look at the flow in the ovaries, and various combined modalities. There is a role for screening for ovarian cancer in young women, for example, that are still interested in preserving their ovaries for fertility-sparing purposes. And there are also women who, for personal reasons, are just not quite ready to undergo a bilateral Salpingo-Oophorectomy, which is removing the ovaries and tubes. And these are women that we do use screening modalities. When you're looking at the population in general, there have been at least 10 studies over the past 10 years that have looked at screening, and there's actually no benefit for screening women who are at low risk for developing ovarian cancer. Unfortunately, when we've looked at screening strategies for women that we know are at high risk for developing ovarian cancer, we've not been able to show that screening can catch these cancers early enough to really affect how these women do. Nevertheless, as I mentioned, these women may not be ready to have their ovaries removed, and so there is some role for screening, although I always counsel my patients about the limitations. The other things that I'd like to talk about, first, we do definitely need to identify these women who are at increased risk. That's the first step. The step is then to talk to women about chemoprevention strategies, about screening, and about surgery. And these are just some of the things I'd like to touch on briefly. So what is the CA-125? That's a blood test. It's a glycoprotein, or basically a protein that's secreted on the surface of many epithelial ovarian cancers. It's often shed in the bloodstream by ovarian tumors. However, it's a very nonspecific marker. It's quite sensitive for women that have advanced disease, and 90% of these women with advanced ovarian cancers will have elevations in their CA-125s. But unfortunately, at that point, it's often too late. Less than half of the women with very early stage cancers have abnormal levels. It is one mechanism that we definitely use to screen women, but it is a nonspecific marker. In young women, for example, there are different things like endometriosis and different bowel inflammation and things of that sort that can cause elevated levels that may not necessarily be related to a cancer. Transvaginal ultrasound is basically a probe in the vagina. It does not require a full bladder. It can visualize the ovaries and fallopian tubes as well as the uterus and the entire pelvis. The anatomy is much better visualized because there's just a shorter distance between the vaginal probe and the organs. It has definitely a higher specificity and sensitivity and a positive predictive value than abdominal ultrasounds, but it's still quite limited for looking at the ovaries and catching cancers early. Which women do we screen for ovarian cancer? So, as I mentioned before, an average risk patient, there's really no value in screening with CA-125s and transvaginal ultrasounds. Many studies have looked at this, and we've not been able to catch cancers early enough and have an appropriate intervention that actually causes women to live longer. We don't know in women that have an intermediate risk, and this is the group of women that definitely requires further study. And these are women that I mentioned before that may have a first-degree relative with ovarian cancer, or personal history of premenopausal breast cancer, but no identified mutation. We do know, as I said before, that women that have a high-risk mutation for developing ovarian cancer may benefit from some type of screening until they're ready to undergo a bilateral Salpingo-Oophorectomy, which means removing their tubes and ovaries. In my opinion, risk-reducing Salpingo-Oophorectomy, which means removing both of the fallopian tubes and ovaries, is really the best strategy to prevent ovarian cancer. It's been shown in many studies to provide approximately 90% risk reduction in the risk of ovarian cancer. And this is just a picture to show you what the uterus and the ovaries and the fallopian tubes look like. Let's see if I can. So this is the uterus and the cervix, and this is what a fallopian tube looks like and an ovary, and another fallopian tube and an ovary, and the bladder is in front of the uterus. And the reason I show this picture is that it's important that the complete ovary and fallopian tubes are removed on both right and left sides. It's important that we as surgeons notify the pathologist that this is a patient who harbors a high-risk mutation for developing an ovarian cancer, because the pathologist will actually section the tube and ovary in very small pieces, 2 microns or less, just to detect any occult cancers, which means any very small, tiny microscopic cancers that we may not be able to see with the naked eye. There have been a lot of studies about looking at whether or not the uterus needs to be removed at the same time that the ovaries are taken out. And the studies have shown that if there is a cancer that's going to develop, it usually develops in the mid portion of the tube, not the portion of the tube that's right next to the uterus. So the studies have actually shown that there really isn't a need to remove the uterus at the time that the ovaries and tubes are taken out, unless there is some other very small risk factor for uterine cancer, which for most patients is usually not present. The reason I bring this up is that the ovaries and tubes can be removed laparoscopically, as Dr. Chong mentioned, which is usually an outpatient surgery with a very small recovery time. There have also been a lot, or I should say just a few studies, looking at the risk reduction in breast cancer, actually, for women that undergo removing the tubes and ovaries. This is a very interesting study that was just published again in 2010, looking at the risk of removing the ovaries and tubes and showing that it does definitely decrease both the risk of ovarian cancer and the risk of breast cancer as well, too. 60% reduction in all-cause mortality, a 56% reduction in breast cancer mortality, and then an 80% reduction in ovarian cancer-specific mortality. I don't want to go through too many data questions and studies at this point in the night, but I just want to show you that there have been at least 6 to 7 studies showing the impact of removing the tubes and ovaries on both breast and BRCA-associated ovarian and gynecologic cancer, and they've all shown a benefit in terms of improving the patient's not only quality of life, but also significantly reducing their risk of gynecologic cancer as well as breast cancer. There have been a handful of studies as well, too, looking at the prevalence or what is the rate of having a very small cancer in the ovary or the fallopian tube at the time they're removed for prophylactic surgery. And there have been a wide range, as you can see, anywhere from 3 to 11% incidence. So that's why it's so important that the surgeon, as a GYN oncologist, tells the pathologist that this is a patient who's potentially at high risk for developing a cancer and that the ovaries and tubes are very carefully assessed and looked at. So a few comments about chemopreventative strategies. As I mentioned, the best strategy for women with BRCA mutations is to undergo risk-reducing Salpingo-Oophorectomy, removing both of the ovaries and fallopian tubes when a woman is done with having children. The recommendation now from the National Health Institute and various national organizations, the Society of GYN Oncologists, a lot of national cancer organizations, is basically to screen women with transvaginal ultrasounds and CA-125s every 6 months until she's ready to undergo removing the tubes and ovaries. Usually the recommended age is about the age of 40 or when she's completed childbearing. Until that time, or for women that are not quite ready to undergo that strategy, oral contraceptive pills, as Dr. Chong mentioned, has been shown to be definitely a risk-reducing strategy. A few studies, well-designed studies, have shown a 50% risk reduction after 5 years of oral contraceptive use and at least a 30% reduction in ever use if women have ever used birth control pills. And this benefit actually persists for at least 10 years. So in women who have BRCA mutations and they're worried about their young daughters who are in their 20s, this is definitely one strategy that I recommend. There are some studies that are now looking at various different chemopreventative agents. These have not been proven yet in any big, large randomized studies looking at COX-2 inhibitors or different anti-inflammatory drugs, PARP inhibitors or PARP ligands. You might have heard about some of these things in the press, and retinoids, and we're basically looking at different chemopreventative strategies as well as different screening strategies. And hopefully if I come talk to this group in the next 10 years, I'll be able to say we've made a lot of progress compared to where we are today. Overall, the recommendations, I think, are pretty straightforward. We really have very limited screening modalities for ovarian cancer, and so I really encourage women who are 40 or older or at least done with childbearing to strongly consider removing their tubes and ovaries. It has a 90% risk reduction. It's important that women know that women are still at risk for what's called primary peritoneal cancer, which is a cancer that arises from the lining that's like a saran wrap lining in the abdomen and pelvis. It looks and acts and behaves very similarly to ovarian cancer and is treated the same way. The risk is the same for any woman in the general population, even someone who doesn't have a high-risk mutation. And then until she is ready to undergo having her ovaries and tubes removed, basically screening with the CA-125s and transvaginal ultrasounds every 6 months, and then the various chemoprotective agents, particularly birth control pills. One thing that I didn't make a slide on, and maybe we can talk about it as a panel, are the use of hormones in women who have undergone risk-reducing bilateral Salpingo-Oophorectomy. I have many women who are 40, 42, 38, who have had their ovaries taken out as well as the tubes and are now in menopause. And it's very challenging to deal with those symptoms in such a young patient. And maybe that's a great question that the panel can expound upon. But There have been some studies looking in women with BRCA mutations who have not had a cancer, who have undergone a bilateral Salpingo-Oophorectomy. The tubes and ovaries have been taken out. These are very small studies, and they have not showed an increased risk of breast cancer in women who have used hormone replacement therapy. It's a very controversial, hot topic, using hormone replacement therapy in general. I think there's definitely a benefit. It's something that I speak to the medical oncologists about pretty carefully who are treating women. If she doesn't have a history of breast cancer, that a very short course of hormone replacement therapy really may be beneficial. What we know in the small studies is that does not increase the risk of breast cancer at that particular time. But there are also other strategies if women want to stay away from hormones in terms of vaginal estrogens or other strategies that do not have estrogen in them at all, like Effexor or Neurontin or different complementary type medications that may help combat some of the side effects without putting her at any increased risk. In terms of ovarian cancer in general, if women do have ovarian cancer, I just want to say that even though it is the silent killer, we've made tremendous strategies and tremendous improvements in really decreasing mortality or decreasing death from ovarian cancer. I think the biggest thing that we've done in the past 10 years are really identifying the women with BRCA mutations and removing their ovaries as a preventative strategy before they even get ovarian cancer. But for these women that unfortunately do have ovarian cancer, we've really extended the survival. It's more an illness of chronic disease at this point by really radical surgeries to remove all the cancer, as well as giving chemotherapy in the belly, which is called intraperitoneal chemotherapy, to really extend the survival and extend the quality of life for these women. And we're definitely studying a lot of these approaches at Columbia. So with that, just want to thank you, and I'd be really happy to take any questions.
Sharon, I'm going to ask you just to have a seat. And I'm going to ask Dr. Chong and Dr. Oratz if they can join the panel up here. Judging by all the questions that I have here and more to come, can bring them up, we're going to try to get to as many as possible, and hopefully we can cover, by covering as many as possible, we'll get to everybody's questions. You guys are clearly a motivated group, so we're going to get started. So the first one, this is actually for Dr. Chong. So should men get tested should get BRCA tested? I think that's a great question.
That's a great question. Men, you aren't off the hook. You're at much less risk than women are, and there are two reasons why men might want to consider testing. BRCA, I made this a little bit overly simplistic in my talk. BRCA 1 and 2 are more alike than they are different, but there are some important differences. For BRCA2 in particular, it's significantly associated with breast cancer in males. The absolute risk is not all that high, but there are about 5% of men who will develop breast cancer, and certainly not something that we would usually think of. And there are slightly increased risk of other cancers in men. Prostate cancer is at a slightly increased risk, not particularly early, but we do recommend screening with digital rectal exams as well as PSA screens. And there may be a slightly increased risk of some other cancers like melanoma and pancreatic cancer for BRCA2 in particular. So that's one reason why men might want to think about testing. The other reason is obviously, as we talked about, for other family members. So for some men, they know there's a BRCA mutation within the family, and lots of times their girls in particular are worried about whether or not they got this. Their daughters may not be wanting to necessarily go through testing at that point in their lives for whatever reason. And if their dads can do the testing and find out their dads are negative, then what their dads don't have, they can't pass it down. So it actually is both a cost-effective as well as a psychologically effective way of potentially dealing with it in the family. So two good reasons. On the other hand, I'll warn you that insurance companies aren't always as enlightened about this. And so many times they will not cover the cost of genetic testing for BRCA in men. And I didn't really talk about this. In general, insurance coverage for women for the testing is very good, but it's an expensive test. It's over $3,500 for the full comprehensive test. For individuals of Ashkenazi Jewish descent, it's a little bit less expensive, a little over $400, but it is expensive. And so that's one of the reasons why, unfortunately, men, I hate to say this, but you get discriminated against in this particular way.
Okay. This is a question for Dr. Oratz. What effect does chemoprevention have on fertility in younger women?
Fertility is a major issue for all of our patients who either have been diagnosed with breast cancer at a young age and are undergoing treatment. Tonight we're focusing not on the patient who's been diagnosed, but on the than the woman who's at high risk. Certainly if we remove the ovaries before a woman has had children, that is going to have a dramatic impact on her fertility, of course. What about these other options? So tamoxifen is used as a risk-reducing strategy for women at increased risk. In premenopausal women, tamoxifen actually can increase ovulation. It causes ovarian cycling, and most young women who are taking tamoxifen, at least under the age of 40, will continue to menstruate every month. That does not mean that we want you getting pregnant while you're taking tamoxifen, because tamoxifen is not something that is healthy for a fetus to be exposed to. If a woman knows that she's at increased risk for developing breast or ovarian cancer and is concerned about fertility, what we would encourage her to do if she's at the appropriate time and place in her life is to have a baby as soon as she can, if that's appropriate for her. But not everyone is in a situation that, makes it so appropriate to just go out and have a baby right away. And if she is then considering either risk-reducing surgery or some other modality and wants to preserve fertility, then we work very closely with our GYN oncology colleagues and our colleagues who work in assisted reproductive technologies to think about either retrieving eggs and freezing them or fertilizing them and freezing embryos, and then discussing what to do with those embryos or eggs, perhaps at a future date, whether that woman herself, if she still has her uterus, could be the carrier, or whether we should think about a surrogate. Sharon, do you want to comment on that at all from the GYN point of view?
No, I was just going to agree with what you were saying. So it's definitely a collaborative effort between the reproductive endocrinologists. Obviously, if a woman, it's the right time in her life for pregnancy, that's a protective effect in terms of at least ovarian cancer. Something that might be interesting to talk about at another point or now are the genetics that are involved with BRCA mutation carriers and the different technologies that the reproductive endocrinologists have now discovered to test for these mutations during IVF. So they have a lot of very interesting technologies that are now available to elicit some of these mutations.
So, question for Dr. Lewin: while removing the ovaries reduces the risk of ovarian cancer, what are the other health risks involved with removing the ovaries?
That's a great question. Obviously, when the ovaries are removed, a woman will go into menopause because she no longer has estrogen or progesterone. So there are other risk factors in terms of osteoporosis and bone health that comes into play, cardiovascular risk. It often becomes a long discussion, important discussion to talk about, particularly women at what age they are or she is when she has her ovaries removed, and other strategies to keep her bones and heart and healthy, as well as to decrease the vasomotor symptoms.
Yeah. Which is why you said we usually recommend waiting until 40.
Exactly.
And when she's done having her children.
Exactly.
Yeah,
hormone replacement therapy now is a very controversial topic. According to the Women's Health Initiative, there's been a lot of information in the press recently. I will just spend a quick second on this if I can. But there are many flaws with that study, but we did learn a lot of important things. And the average age of the women in the Women's Health Initiative was approximately 62 to 63, which is a very different population of women than women who are 40 or 42 who are undergoing removing both their tubes and ovaries. And so I think we've learned as a community that hormone replacement therapy, a lot of pros and cons. It's important to have a discussion, but we've not really studied it in young women who are 40, 42, other than the two small studies I mentioned looking in women with BRCA mutations. And we've shown in those women who don't have a breast cancer already that we think it's safe, but it's definitely something that requires a lot of discussion about. But overall, the thought is to have no hormones if you're menopausal, or as slow a dose as possible for as short a course.
Wendy, the question here is, has there been any improvement in testing for the BRCA1 or BRCA2 mutations since the myriad tests done in the late 1990s?
Right. So I'm going to do a little bit of technical speak here. So the the way that originally genetic testing was done for BRCA1 and 2 is it was like taking a page out of a book, out of an encyclopedia, and proofreading it for any typos. And so literally the way that this was done by Myriad originally is they would look for single letters that were either misspelled, an A instead of a T, or else small numbers of letters that were missing, a couple letters extra, a couple letters missing. And that was the original test that was done for about the first 8 years of testing. After that, Myriad realized that there could actually be different types of mistakes, where you might have that entire page ripped out of your book, or you might have an entire paragraph missing, that they were missing in the way that they did the original test. So actually, after some studies by Mary Claire King showed sort of the flaw in the way that they were doing the testing, they revised the test. And so there's actually a new version, an added version, that some women that, for instance, there were some women that in the old days, they tested negative on the test, but they had very strong family history still, particularly of ovarian cancer. And we and others have gone back to some of those families and tested them and realized that, in fact, they had one of these other types of mutations that were missed by the original testing technology. It's not a very large percentage, and again, it's mostly those that have ovarian cancer in the family and strong family histories of early breast cancer. So for any of you that had testing in the old days, your testing is probably still good and valid, but if you feel like your family still walks like a duck, talks like a duck, we should think about whether or not it's worthwhile going back and readdressing the question.
Wendy, do you want to just comment briefly on the lawsuit that was against Myriad and what that means for patients that want to undergo genetic testing?
Sure. So this is something if any of you have heard me talk about this, I feel very passionately about. So the genetic testing is done by a company called Myriad Genetics out in Utah. And I actually think they do a relatively good job of testing these days from a technical point of view. But it's been frustrating for me, and I think probably for people like you, because there's really been a single game in town. There's been one company doing the testing from day one in the United States. And because of that, they've basically had a stranglehold both on the price of the testing as well as from a technical point of view, the way they did the testing, and really not correcting some of the errors they had in the first place.
And the entire world.
And right, in the United States. The other thing that they've had a stranglehold on, as we started alluding to, is that some women get test results that are basically big question marks. They write in their report, variant of uncertain clinical significance. And quite honestly, they've been very lazy about trying to understand and reinterpret those results better. And so there are a lot of women, and I have to say disproportionately women who are sort of from the four corners of the world. That is, that if you happen to be Asian, African American, Hispanic, you're more likely to get one of these variants of uncertain significance. And they have actually tied the hands of people like me behind my back because I don't have access to their data to better interpret what those genetic variations mean. I do lots of sort of trickery in terms of trying to make predictions, but I can't know as much as they know, and they won't give me and other researchers access to that data. So because of that, knowing that the reason they can do this is they have patents on the genes BRCA1 and 2. And so because of that, they have excluded anyone else in the United States from doing any of the genetic testing. This is different in different parts of the world. In Canada, for instance, if you're north of the border, the cost of your BRCA testing is significantly lower, and I think you actually get a better product because they're not subject to the same type of patent laws we are here in the United States. Same is true in Europe, Australia, other parts of the world. So because of this, I actually went to Congress, and I was a little upset by this, not just because of BRCA1 and 2, but other genetic tests as well, where I didn't think it was right that your genes, which are your genes, and my genes and everyone else's genes, but someone could patent your genes. To me, that is a product of nature, right? That is something, if you believe in God, it was made by God. If you don't believe in God, whatever, but it is not something that they invented. Myriad didn't create it. They didn't invent it. They're not doing anything to it when they're doing the genetic testing except reading out your codes. To me, that's not something that should be patented. And so I went to Congress, and I opened my big mouth and said that, and I actually didn't think anyone would listen or pay attention. But I was surprised because the ACLU actually came to me a month later and said, you know what, that's a really interesting concept. And of all people, the ACLU I didn't expect would be the ones that would be excited about this, but that's okay. So Chris Hansen has taken up the charge and has actually had a lawsuit, and many of you may know either other breast cancer organizations, other professional organizations have gotten behind this and actually agree with our position, which is that genes are a product of nature. They can't be patented. They shouldn't be patented. And I'm very proud to say we won round one. That is that. Yeah. That is that. Judge Sweet actually ruled in our favor that the information content of genes cannot be patented. That's something that UNI is something that they can't own. This is going to the next court. It will go to the next Court of Appeals. I have to say that very recently the Department of Justice, for any of you that read the piece in the New York Times, has again decided in our favor, which is very interesting because they're in direct contrast to the Patent Office, but the Department of Justice actually believes that we are in the right in this case. And I'm hopeful that we'll win round 2, but if not, I can almost guarantee it's going to go all the way up to the Supreme Court because this is a very fundamental part of what I believe.
This is really important work that Wendy's doing. She's very understated on this, but this is really important, so I thought it was really important that you talk about this. Thank you. So the next question for Dr. Oretz, and I think this is a very quick question. I just want to make sure that this gets addressed really quickly because I think this was maybe not didn't get through. Can tamoxifen cause the onset of menopause? Right. Very quickly.
So very quickly, in young women taking tamoxifen, let's say under the age of 40, tamoxifen will not cause the onset of menopause. In women who are closer to their natural menopause, let's say 45 and older, maybe taking tamoxifen maybe speeds that up a little bit. It's impossible for us to measure that or know that, but I think that's our clinical experience, at least from the women who we're treating with breast cancer. We have lots of experience using tamoxifen in that age group. Between 40 and 45, it's variable. Menopause is variable. There are some women I see in my practice who are continuing to menstruate well into their mid-50s. There are some women who reach menopause in their 40s. It's a very multifactorial process. But tamoxifen in and of itself does not cause menopause in young women. Simple answer.
Dr. Lewin, can you do a laparoscopic oophorectomy with a patient that has mesh from an umbilical hernia repair? Very technical.
Yes, you can. Laparoscopy is a wonderful invention, and so I really offer that to all my patients. We can try. There are different sites you can put the camera port in, basically, and avoid the mesh. But yes, a mesh is not a contraindication to a laparoscopic surgery. Great question.
Okay.
And I'll say something that Sharon won't say, I think, which is that if a woman is considering a risk-reducing ovarian surgery, it is preferable, as a medical oncologist, I would make the recommendation that that woman see a GYN oncologist, so a gynecologic surgeon who is really experienced at doing this operation correctly. There are certain technical aspects to it, pelvic washing. You alluded to the way the pathologist looks at the specimen. Not everyone everywhere in the country has access to a GYN oncologist. There are many excellent gynecologists who know how to do this operation. Here in New York City, we're fortunate to have so many medical centers with so many experts that I would encourage women to seek that expertise.
Yeah. Wendy, this is a question about the GINA law. The person who asked this question writes, but says they read that the GINA law does not protect you if you have been diagnosed with breast cancer. Can you clarify?
Right. So if you've had cancer, you've had cancer. And so in terms of any of your insurance that goes with that, you've had that diagnosis. Just like, for instance, if you'd had, I don't know, a heart attack, you'd have a heart attack, regardless of what caused that. What the GINA protects you against is any genetic predisposition to anything else in the future. So if, for instance, you had your breast cancer and you had a BRCA mutation, someone couldn't discriminate against the possibility of you developing ovarian cancer as a possibility in the future just because you were at increased risk. But if you have had cancer, we unfortunately can't erase or change that fact in terms of the way the insurance companies look at it.
Okay. Two questions. One for Dr. Oretz. So this is a BRCA2 woman, 45, had a risk-reducing BSO and hysterectomy at age 44. So how much additional benefit will there be if she uses chemoprevention?
Great question. And I do want to emphasize the point that Dr. Lewin made, that if a premenopausal woman has the ovaries removed and she's never had breast cancer, that's a major reduction, almost a 50% reduction in the risk of breast cancer. Probably not such a strong reduction in women who are postmenopausal, right? That makes sense. The ovaries aren't producing as much estrogen. The issue of tamoxifen overall in mutation carriers is very difficult for us to answer. There are no studies that were designed specifically looking at tamoxifen in women with BRCA mutations. In the very large national trial that looked at tamoxifen as a preventive agent, it was actually Mary Claire King who went back and said, let's see how many women had BRCA mutations in that group. It was a relatively small number. It seems like there's some advantage to using tamoxifen, very difficult to quantify.
Okay. For Dr. Lewin, given the findings that ovarian cancer often develops in the tubes, has there been any study of efficacy of just removing the tubes for women who want to preserve fertility and then use IVF if the woman wants to use her own eggs?
Maybe I should clarify. It's a little difficult to ascertain once a woman has an ovarian cancer or fallopian tube cancer, which it started in, because we can't catch these when they're small enough. We've looked back, though, at women who have had some of these fallopian tube cancers, and they've started in the middle of the tube rather than at the end of the tube by the uterus. I just hope I was clear about that. I don't think that's been looked at because it's such a small population of patients. We're not able to separate out the risk of getting an ovarian cancer versus a fallopian tube cancer in these women who are high risk. We know that these cancers are treated the same. Women with a BRCA mutation are at high risk for getting one of these two types of cancers. So to really prevent the cancers in general, it would be best to remove both organs, the fallopian tube and the ovary. If women haven't gotten pregnant at that time, we would recommend first getting pregnant if that's something that she wants to do, and then have her ovaries taken out. There are other reproductive strategies, harvesting the eggs, and then having a surrogate if that's something she wants to do. It's a very complicated individual decision, but definitely an option. But it wouldn't make sense from a cancer preventative strategy just to remove the tubes and not the ovaries.
Okay. For Dr. Chong, this person asked, my sister is scheduled for genetic testing, so she wants me and my twin sister to go through it too. Can more data be obtained by all three of us going through it, or will my sister's test be sufficient? And as a background, she writes, sister went through testing, sister going through testing is 41, the twins are 39, mom died of ovarian cancer at age 57.
Right. So this is a scenario, I think I probably got this, where which is not uncommon, which is where the people in the family who've had cancer, her mom in particular, is passed away, and where there's no ability to test someone who's had cancer in the family. So the difficulty becomes sometimes when no one living in the family has had cancer, one person will get tested and will get a negative genetic test result, as an example. The difficulty is that genetic test result being negative could come by one of two mechanisms. Number one was that her mom really did have ovarian cancer due to one of these BRCA1 mutations. But remember, her mom would have had 2 copies of the gene, and potentially she got lucky and got the normal copy of the gene. We can't distinguish that from the second possibility, which is that her mom got the ovarian cancer for some completely different reason, either a HNPCC gene or something else that had nothing to do with genes whatsoever. And then her mom's genes both looked completely normal for BRCA1 and 2, and therefore she inherited normal copies of the genes. So by only one sister getting that negative genetic test result, you can't distinguish between those two possibilities. What they're advising in terms of the other sisters getting tested is that the more sisters that get tested, the more likely it is that one of them would turn out positive if, in fact, her mother was positive. And you can go through very complex calculations to figure out those statistics. But the more individuals that test negative, the lower the likelihood that her mother would have, in fact, carried a BRCA1 or 2 mutation. But you can never make that number go to 0 unless you actually had some way of being able to test her mother directly. So the identical twins, one thing that's interesting that comes up with these, I don't know if these are in fact identical twins, but if they are in fact identical, really in terms of saving your money, you can just test one of them because genetically, obviously, one's going to tell you the other. The one thing I do want to bring up with this, though, is that, again, sometimes And I have to say, I've had a lot of patients in hospice care where maybe they're not thinking about the testing for themselves, but they're thinking about it for another relative. And maybe the family isn't ready to think about genetic testing right at that moment. A lot of complex things are going on in the family, and especially if someone's dying. I do want to just bring up the option that you can bank a sample of blood on an individual, and you can do it very inexpensively, less than $100. There are commercial companies that do this, and it gives the option to families to deal with this on their terms rather than being forced to deal with it just on whatever they've been dealt with. And it leaves open that option then of doing the genetic testing on someone where it really will give the information to the family that they need. So just think about that, you know, if you ever do find a friend or someone in that situation.
This is the last question, and either Dr. Oratz or Dr. Lewin can take this. You find that you're BRCA1 or BRCA2 positive and you're high risk. What if you choose to have a mastectomy or take out your ovaries? Does medical insurance treat this as elective surgery, or do you have to cover the cost?
I think it depends on the insurance carrier, and it depends on whether or not you've had any other abnormalities. So if there's been an abnormal mammogram, if you've had a biopsy that showed perhaps some other abnormality in the breast tissue that might justify doing further surgery. So it's a very case-by-case basis. I think in my personal experience with the women who I work with, most often they have been able to have their surgery covered by insurance. Not always the plastic surgery. That sometimes is a little bit trickier, but again, most often we get coverage. In terms of the ovarian surgery?
I would agree. I have not, in my personal experience, had any trouble getting the prophylactic surgery paid for.
I've been able to get my patients covered.
And I take all insurances, so everything.
Yeah, it hasn't really been an issue
recognized.
if you're gene positive. Yeah. So so that's been the case. So thank you so much. I want to, if we can give our speakers a round of applause. This was really informative. Thank you so much. We're going to move on to the next half of our session. I'm going to ask our patients to come up. Oh, am I hiding them? Okay. So I'm going to just move along here. So we're really fortunate to have three really impressive and brave patients who are willing to share their experiences with us being high risk. I'm going to introduce them, and then they're going to just talk about their experiences. We have first Lisa Held to my immediate left, followed by Patricia Brett and Navina Hakel. So first, I'm going to start with Lisa, and I'm going to have each of them just first give a very brief couple of minutes introduction about their past experiences, about what makes them high risk. I'm going to let them speak first, and then we'll open it up to questions both from you and from me, and we'll go from there, okay? So Lisa?
Hi, thanks, Dr. Joseph. So I have a BRCA2 mutation. I had genetic testing when I was about 19, which is very young. Most people do not have it that young. My mother actually had pancreatic cancer at a very young age, about 45. She was diagnosed and passed away shortly after. And her sister had breast cancer twice before the age of 35. So this kind of pattern, and actually I don't think this came up at all, but in BRCA2 carriers, there's a very slight increased risk of pancreatic cancer. One of their doctors saw this link. They're both very young, and they were tested for the mutation. So, and they had it. So I was tested since I knew that I might have it. And because I was so young, I didn't do anything for a while. And then in the past few years, basically, I've been under intense surveillance. Actually, Dr. Oratz is my doctor. She's great.
She just stepped out.
But so at this point, I'm doing exams with Dr. Oratz, MRIs once a year, mammograms, sonograms every 6 months. I have definitely decided that I'm going to have risk-reducing surgery. I mean, in terms of my ovaries, I haven't really even thought about that at this point because I'm nowhere near even having children or anything like that. But
How old are you now, Lisa?
25.
Okay.
But in terms of the mastectomy, I've definitely decided that I'm going to do it. It's just really a matter of fitting it into my life and deciding when the right time is. So I'm basically just in the surveillance for now, and in the next few years we'll probably decide when to fit that in. Yeah, and I mean, I feel really lucky to have the information that my mom and my aunt didn't have, and so to me it's just really important to take control and kind of as much as you can. Obviously you can't take complete control, but just to be able to make the decisions and just be as informed as possible. So.
Patricia?
Hi. So when I was young, I lost 3 aunts to breast cancer, 3 of my dad's sisters. And one of them was my dad's oldest sister, who was a nun. The other was his baby sister, who, when she died at 44, left behind 6 kids. And then his other sister, Francie, had breast cancer and then ovarian cancer. So, you know, 3 of my father's 6 sisters to breast cancer and 1 to colon. So we always knew it was in the family. And then about 13 years ago, my sister was diagnosed with breast cancer. So my sister was the first one in our generation. After my sister was diagnosed, there have since been 6 additional breast cancers, all first cousins, 1 ovarian cancer. And so we were very fortunate in that one of my cousins entered a high-risk study at McGee Hospital in Pittsburgh. And by entering that study, it actually diagnosed her breast cancer. So she was diagnosed shortly after my sister. And because we had that cancer diagnosis in our generation, she was able to have the genetic testing done. And we found out that, in fact, we were BRCA1 positive. So in 2001, I found out that I was BRCA1 positive. So of my generation, my father passed the gene on to 2 of his 6 daughters. And so in 2003, when my son was 2, I had a risk-reducing bilateral mastectomy. And in May of 2007, at the age of 43, I had my ovaries and my tubes out. So they were difficult surgeries and they were tough decisions, but I felt that my family was really, really fortunate to have this knowledge, and that my generation could really make informed decisions that my aunts weren't able to make. So we were able to take charge of our own health and ensure that we would be able to be here for our own children. So,
Thank you. Navina?
So I'm from India. I'm 44 years old. I have 2 children, 14 and 8. And we had, growing up in India, we had a family. I had a family history. My mother actually is a 22-year ovarian cancer survivor. So I'm happy to share that with you. But she was diagnosed in India, 22 years ago, when things were, it's a different world. The medical treatment there is fantastic in many ways, but it's not as advanced as here. And I'm a big believer that if you have a great doctor and you have, you're proactive, like my mother was, who got herself tested 22 years ago in India when her sister was diagnosed with ovarian cancer, you can make, have a very good outcome. So I just really want to convey that message. Subsequently, I discovered I was BRCA1 positive, and at the age of, I think it was 37, I had my ovaries out. I've never regretted it. I'm now 44, as I said, and I've had, good health since then. I behaved outrageously badly at the time of the news when I heard, and I think Columbia Presbyterian will not forget the screaming, wailing, drama that took place in the corridors, and I really want to thank all the doctors there, and Donna Russo in particular, for the good advice, for the fact that it wasn't just a lot of statistics, but it was really a perspective on what this information means to you as an individual, how can you deal with it. And I have a special, gratitude for women who are older and who've lived their lives, passed through these childbearing years and all of that, and have all that wisdom to give you. I think it's a great sisterhood, something I've benefited from. So thanks to all of you at Columbia. And just to say that we're all very lucky in the end to have the information. So thank you.
I'm going to get started with some questions, and if anyone has questions, just feel free to pass them down to me. Navina, if I remember correctly, you have several family members with ovarian cancer?
Yes.
Do you have any family members with breast cancer?
I have a mixture of breast and ovarian cancer, in the family.
Okay.
But I would say that we have incredible stories of people making it really well through all of this. My cousin is 29. She had a galloping breast cancer. She, she's done very well. But I've had like 50% ovarian, 50% breast in the family, I would say.
That was very impressive. And Lisa, being told at the age of 19 that you were BRCA, how did you handle that?
I actually had an awful experience with getting my genetic information, and it definitely speaks to just the importance of genetic counseling. It wasn't that long ago, but I think still just even 7 years ago, so it was different in that people didn't know as much about genetic counseling. And my gynecologist, I told him I wanted the test, and they sent away for it, and he gave it to me, and I was at college, and he called me over the phone and gave me the results. And I had my mother at the time was not able to help me because she was so sick, and I really had no idea what it meant. And then I even had I won't get too far into it, but I had a worse experience because I went with my aunt to a chemo treatment, and she asked her oncologist, "Oh, my niece just found out she has BRCA2. What should she do?" And he was an extremely callous doctor, and he said something along the lines of, "Well, you better find someone to marry quick and have kids because you're going to have to get rid of your breasts and ovaries as quickly as possible." It's I'm laughing and it's funny, and I'm a strong person, and I knew that was not what I was going to do. But I think it's definitely important. I don't know if there's a specific age I think it's probably very different for everyone, what age you're ready to go get tested. But just having a genetic counselor there to take you through it and really have the counseling, I think, is definitely really important.
Right.
Yeah.
So basically your doctor just took the blood, did the blood test. No one sat down with you and went through the family tree and brought you into the office to go over the results. He just told you over the phone.
Yeah.
All right, at 19. Oh, God, okay. Patricia, at what point did you decide, you talked about it was your family member that first got tested and found out, and then did you immediately go and get tested, or was there some time before you went ahead and got tested?
That's a good question. It's a little blurry because my son was a baby, and I was dealing with an infant, and so I knew about the gene, but I'm not sure if I waited 6 months or I waited a year. But I definitely waited until my son was a year old and I was ready to actually think about it.
Right.
So I probably had the information for somewhere like 6 months to a year before I actually did the testing.
Okay.
And then for me, I'd always done routine mammograms starting at the age of 30 because I knew that breast cancer was in the family way before we learned about the gene. But once I found out that I was positive for the gene, I actually saw a breast surgeon for the first time and had MRIs done. And so I had a period of an entire summer of not knowing whether or not I had breast cancer. I needed a certain type of biopsy. And so I think it was that 3 to 4 month window of waiting for the correct tests, waiting for those results, having that biopsy. And that window of not knowing whether or not I had breast cancer, I realized that I didn't want to spend the rest of my life living that way.
Right.
And once I had the surgical biopsy and it came back negative, I realized I'm ready to just eliminate my risk. So that was really an important part of the process for me, I think.
Okay. So you did the testing and then you did the surgery, or what was the timeline between?
I had the testing done in March. And it wasn't until the end of August that I found out that my biopsies came back negative.
Okay.
And then it was the next January. So it was within a year that I actually had my breast removed of finding out that I had the gene.
So you didn't, it was pretty soon after that. Yeah.
Yeah, I mean,
After you found out.
my son was 2, and it was all about my staying alive for him. And, you know, seeing my aunt pass when I was 11 and knowing that she left behind young kids, for me it was all about making sure I was there for my son and for the next generation.
Okay.
And then, you know, having the ovaries out, that was a whole second decision-making process.
Okay. And Navina, at what point did you decide, what finally prompted you to go get tested?
I think so my mother had been in England for a few years and had participated in Dr. Bruce Ponder's study, which was the initial study, I think, that helped, or one of the big studies that helped find these genes in the first place. So Dr. Ponder, I'd been very lucky in my life. From a young age, I'd known Dr. Ponder and Dr. Carmel, a couple of other doctors there, and they had always said, when you finished having your children, you must get yourself tested. So I finished having my children, and I had a very, by the way, traumatic history of pregnancies and catastrophes and disasters in that area. So I was actually quite fragile and vulnerable when I decided to do the test, and also completely convinced that I did not have this BRCA1. I thought, this is the piece of good news I deserve at the end of everything that I've been through. And that was my mentality. So to go in, so that was, I mean, I was following Dr. Ponder's advice, but just really thinking that this is, you know, formality. This is now me getting through all of this. I was completely unprepared for the news that I was, you know, actually positive. And then after that, after I received the news, for about a year, I was really in a bad state. Everyone in my life was very patient with me, and really, I took it so badly that, I mean, just being in this panel today is a miracle for me. I can't believe that I'm actually talking sanely about it. I really just, I'm sharing this with you because I know some people have a really hard time dealing with this information. I'm not like Lisa, I have such admiration for you and you, but I was completely different. Basically then I've realized now that some of the things that I considered the worst pieces of luck actually turned out to be the best, because a year after that, when I started ductal lavage as part of the extra screening, they found a mild atypia. And again, I thought, my God, why me and how this? But that was what made me really take the step towards a prophylactic oophorectomy. And now looking back at it, I think I'm so lucky I had those atypical cells, because without them, I would never have had the impetus to make the decision. And I have now, and you know, there were difficulties, but I barely think about it anymore. I'm just living my life, and that's the best thing that I can say.
How, I mean, this is just for any of you to answer, but how has knowing that you have the BRCA mutation affected your relationships with either your family or your friends? Did it, you know, Patricia, with your spouse or with your?
Well, my husband was incredibly supportive of the surgery from the beginning, but what was difficult is that I had a lot of friends who were not. And a lot of people just didn't understand why I would have healthy breasts removed. Yeah. They thought I was a hypochondriac. They didn't quite understand it. Right. And so I sort of just stopped telling people because I didn't want to hear anybody else's opinion. And so even now sometimes it's hard to remember who knows about my surgery and who doesn't. You know, so it's I had to be selective after a certain amount of time, because unless you've been through loss in your family, and unless you're actually faced with learning that you have the gene yourself, you don't know what the decision making is like. So.
I'm lucky too. I mean, I have a really supportive partner. I've been with my boyfriend for several years, but, you know, there was obviously a conversation at some point that was just me like, by the way, I have to tell you, in a few years I'm probably going to get rid of my breasts, so how do you feel about that? And he, it was very emotional, but, I mean, he's been incredibly supportive, and actually, I'm a journalist, and I just interviewed a lot of people about their relationships, and it just reminded me of this funny thing. This one woman I interviewed about it said that when she found out she had the gene, that she would use it as a test on potential partners. She said, I would say, so I have this gene, and, can you handle it? Because if you can't, well, there's going to be things coming up in life.
It's a deal breaker.
Yeah, I mean, and it's, I mean, in a way, yeah, we have this piece of information that is horrible and hard to deal with and intense for anyone. And you are asking a lot of someone to be able to handle it. But at the same time, I mean, in 10 years, I might have a heart attack or I might get another disease. So, you really don't know what's going to happen. And just knowing that they can be there for you no matter what, I think is important. So, yeah. And also, the other relationship that I can think of that's been affected is I have siblings, and my older sister was tested and was negative. And, I mean, I think it's brought us closer together, but it is interesting, the dynamic that that happens in a family as people get tested. And my brother actually is a lot older and has a daughter, and he hasn't been tested. So that's been an interesting thing to deal with because he doesn't want to be tested, but now he has a daughter, so... those conversations are starting to happen,
Right.
and that's just, interesting. It'll keep developing, I guess, as his
Right.
daughter gets older. But
Yeah.
Well, I guess in my case, I'd really contextualize the relationships and the effect on relationships in terms of my community and my ethnic background. Not everybody coming from India, it's a traditional society in a certain sort of way. It's a very, complex place, just like this one. But one thing is for sure is that attitudes to the body, to medicine, to decision-making, to relationships, to sexual relationships, marital relationships, and all of that are quite different. So I couldn't, easily encapsulate what that means, but essentially between the pole of sort of fatalism, which is one great element, and the feeling that you don't really have scientific control over your life, and you don't need to, and you shouldn't, because there's a higher power, and you have to acknowledge that. That's both a good thing and a bad thing when you face challenges in life. That's one element of it. And the other element is the fact that I would honestly say I find it hard to talk to any of my relatives openly about this issue in India, and even my own mother, and we all avoid the topic. And it's much easier for me to talk to people I don't know at all than to have a cousin or somebody and try and openly talk to them about it. It's just very awkward. So, and I'm sure people from other ethnic communities also feel that those constraints sometimes. It's just not a scientific, open, free discourse like you have in other communities.
Yeah. So. Absolutely, absolutely. How are we doing with time? Okay, so there's a book that came out recently called Previvers. And I know, Patricia, when I first met you, you introduced yourself as a previver. And I just wanted to, and that was actually the first time I had heard the term, actually. And I just wanted to get a sense from all of you, like, what do you think of that term? And in terms of, obviously you consider yourself a previver, and so you obviously don't have a issue with it, but it was actually the first time I'd heard it, and the book now has come out. Obviously, I actually got the book and I looked at it, but I found that an interesting term to call yourself a previver, and I just wanted to get a sense from you about what you think of that term.
Well, the term was actually coined, I think, by Force, an organization called Facing Our Risk of Cancer and Power, and I believe previver. The definition is someone who's survived the increased risk of breast or ovarian cancer. And so for me, I've never been told you have breast cancer or you have ovarian cancer. And I don't know what that's like. And so I wouldn't want to define myself as a survivor because I think that's not fair to someone who actually has heard those words. And so for me, I kind of like that word Previvor because it kind of gives me a category that I fit into. And since the Dina Rothport book, The Previvors, has come out, there's been a little bit of backlash on the internet. People have said, well, what is this with Previvors and why do they need their own word? And if you go on the web and you can look at some of this. But to me, I kind of like the word because at least I know that there's some zone that I fit into. There are other people like me who have gone through this surgery to eliminate risk. And my experience isn't the same as someone who's received a diagnosis of breast cancer. And, I wouldn't want to take something away from them. So for me, I think it's a good word, and it helps me, and it helps to have other people understand why I did what I did. So,
yeah, fair enough.
Yeah, I mean, I'll just say that I agree, basically. I just think, I think for a long time, too, a lot of women who had increased risk didn't know where to find other women that were dealing with similar things, and FORCE really started to bring people together and just gives you sort of people that understand where you're coming from, and yeah, I'll just echo everything.
Do you all know what
said.
FORCE is? FORCE is an organization for women who are at increased risk for breast and ovarian cancer. Yep. FORCE, FORCE.
Yep.
Okay.
I mean, the other thing is, I did all the surgery I did so that I never have to be told you have cancer, right? Mm-hmm. So, you can't then put yourself in a category of survivor if you've said, I don't want to have cancer, so.
I guess I see it in terms of the psychological state a person is in after they receive a devastating piece of news, whether it's the fact that you have this genetic, which for me was utterly devastating. It was as bad as being told, if not worse, a diagnosis. I mean, there was absolutely no difference for me in terms of the impact that it had on me. It was huge. And so for me to feel, I felt instant kinship with people who were suffering from the disease. I felt that this term Previvor links us but doesn't obviously put us in the same category, so I do agree entirely with what you're saying. And I think it's a recognition, really, of the fact that the anxiety that you feel as a survivor, as a Previvor, as somebody who's got a diagnosis of any kind, is that that quality of life is filled with now, your life is filled with anxiety, and it's a recognition of the fact that it is. And, it makes you actually face up to something. You have something that has an effect and impact on your life, and it has a name and a category, and you are it. And it's sort of very, it sort of helped me a lot to feel that there is this little world or category that actually recognizes my particular mental, emotional, physical state. So I like the term, yeah.
And so there is a book that recently came out earlier this year called Previvors for women, and has a wealth of information for women who are who are at increased risk for breast cancer and ovarian cancer. So if you're, thinking about this type of surgery, it is actually a very good guide. So actually, we're running out of time, so we're going to have to close. So if anyone has questions for our panelists, you can feel free to talk to them afterwards. And the other thing I also wanted to mention, which I forgot, Patricia actually has her own company and has a line of swimwear for women who have had breast surgery. So I think there's information outside if you want to take that before you leave, too. And before we leave, we're going to have we have a raffle. We always have a raffle. So kitties will kill me if we don't do the raffle. So we're going to close up. So how many are we doing?
We're doing 5.
5? Okay. So thank you so much for coming. So the first winner, we have Sandy Baker. Who's Sandy? Where's Sandy? She's right here. What did she win? Okay, here we go. Okay. And I'm going to, one more. Okay. Svetlana Didorenko. She's right here, right there. Okay. Okay, and Brenda Pedro. Is Brenda still here? Oh, there she is. This is the reward for staying for the whole session.
Oh, okay.
Okay. We're doing 5, right? Yeah. Deborah Polinsky. Congrats. And one last. Mallory Lowenstein.
Mallory here?
Is Mallory here? Oh, I'll pull another one then. Eloise Wood. Ah. See, aren't you glad you stayed? Okay, have a good night, everyone. Okay.